Thanks very much for asking me to talk. I'm totally honored to be here. I actually put recordings on my talk as well, but I'm going to talk instead myself because it's probably nicer to talk through it. As Dave said, I work in Leeds, and my talk is on toe transfer technique. This is actually my first toe transfer that I did solo, which is in 2013, or sorry, 2003. God, I wish it was 2013. Anyway, 2003. It's a long time ago. Sorry, guys. And anybody who's come through Leeds will recognize some of these people who still work in theatre with us, which is just fantastic. This was a case, and not that I had any pressure, but obviously Simon was around next door doing some other complicated thing. Dave, you just gone, I think, back to Australia. And then these two guys pitched up. Harry and Raja came just to visit for the day. So I didn't have any extra pressure. But recently, Harry was talking at one of the instructional courses, and he mentioned to me that he remembered this day too, because obviously it was a very important, big day for me, and he remembered being there. So that was kind of nice. Anyway, what I wanted to say was the toe transfer technique, or doing toe transfers, is been part of Leeds for decades now, really. I'm not sure I have a lot of new things to add, to be honest. Maybe we've changed things slightly, or I've had my own interpretation on flap raising, but you know, it's a fairly standard technique. This is our new hospital, so again, anybody who's visited Leeds will know that we really, this is not coming a minute too soon. So that's really good. This is obviously just a picture of it, so I hope it looks like that. And then, you know, the whole thing is, it's really the team of people that make how everything works. So this is a fabulous group of people that I'm very fortunate to work with, and this really is our hospital. Just a few things about toe transfer, things that I think are probably important to, you know, it sometimes can be a bit of a controversial technique or thing to do in a small child. We have a brilliant setup in Leeds because it's been there for so long, with psychology and physiotherapy support, with counselling for patients. But some of the key things that are important to remember are, when we're doing the toe reconstructions, it's not really just for those children for hand reconstruction. We have to remember those children who have visual impairment, as in this particular child who had these toe transfers, was partially sighted and needed hands for Braille. And the other one is obviously the child with hearing deficits, who we all know that sign language needs four fingers and a thumb. So that's something that came to light for me doing policizations, actually. But it's important for patients, those particular patients, that they have a full complement of digits. Apart from the cosmetic and functional aspects for hands, there's other drivers as well. Another group that's very important is those patients with, or those children with, bilateral deformities, where obviously anything we can do to improve length and stability and mobility of the hands is extremely important, as in this child. So here we go, same child, just to show the improvement in the function and grasp. And obviously what we can see is that, you know, it is fine to be able to stabilize an object against your chest and work very closely against yourself, but that's not really going forward for independence in adult life. So, you know, very few things you do in adult life where you hold something up against your chest and you try to manipulate it. It's just not really feasible. It's not practical. It's not what everybody else does. And that's where things like toe transfers and digit reconstruction, as in this child, it totally allows them to work away from the body, do independent tasks apart from everything else. So they're probably two of the biggest drivers. And then there's all the other things, you know, about functionality of the hand itself and bimanual activities. So just moving on to the type of toe transfer, I know there's so many different options for toe transfer, but the one for me that is key is second toe. And that's the one I do the most. I have to say, I very rarely take the great toe. And the reason for that is I think the donor site is too big. You know, very happily take 2 second toes, you know, no problem at all. And I feel the donor site is very acceptable. But taking a great toe, I feel is a big ask in a child, especially if they've got, you know, congenital anomaly. But I'm looking forward to hearing what other people think. There's always a lot of talk about the vascular anatomy for toe transfer. And it's really interesting. And we, of course, need to know it extensively before we take on these cases. And there's been a lot of really good studies on it. Joe Upton obviously did some very early work on it a long time ago, and it's still valid today. But I think, you know, the techniques that we use is really, you know, distal to proximal. And in that case, it really just matters, is it dorsal or volar to the metatarsal, intermetatarsal ligament when you're doing the toe raising, I think. So that just makes it a lot more simple. I mean, you can discuss, is it, you know, is it ABCD or whatever afterwards, but on the practicalities when you're actually raising it, the issues are, is it on the top of the foot or the bottom? Because that does make a difference for the complexity, and it's more difficult. A plantar system, I personally think, is quite a lot more difficult to raise than a dorsal system, but you just have to do it and follow the artery. So planning is very straightforward. You know, everything is related to the point of bony fixation, and the skin that we can take on the foot is fairly limited. If you want to have a good donor site, we generally take this kind of like extended triangle. Obviously we need vessels, nerves, and extensor and flexor tendons, and all of these. I think probably the one thing I'd say is just make sure to take as much of everything as you can lengthwise, because you always, you know, it's much easier to have too much than too little, which can happen. And if that does happen, you just have to extend whatever element it is. But it's better to have too much, and that's why measuring is a good idea. Measuring at the hand and measuring on the foot as well. And I'm hoping this video is going to work. If not, it might be on the next slide. Actually, hang on a second. Yeah. Yeah, here we go. Oh, hang on. Oh, sorry. It does work, actually. I had it working a minute ago, so. Sorry, I'll just be a second trying to get this to work now. Hooray, it's working. Sorry, I was having a bit of a panic there. So this is a video that we did a long time ago. These are edits, and I'm sorry about the definition, actually, just looking at it there. But this is the, you know, the raising of the toe. This is just to find the tissue planes. The first thing, obviously, is the dorsal venous system, then raising the plane just above it. I'm sure all of you are familiar with this as I am. And then the next thing is really going down looking for the artery, which is, you know, usually I personally still do this, which is taking the vessel to the great toe, putting a little clip on that vessel, which you'll just see now in a second. Lick a clip on that, and then using that as a handle. So then you're really not interfering with the digital artery to the second toe at all. So you've got the pedicle to dissect, and then you can see there just dissecting out whether it's above or below the intermetatarsal ligament. And then once you've got that, once you've decided that, and sometimes that can be a bit of a decision, because there's oftentimes there will be an artery going above and below the ligament, but you kind of have to go with your instinct and see if there's a vessel there, and then follow it along. And then the next thing is the extensor tendons, as seen here, looking at the brevis and the longus and deciding. And these are good things to check as you go along, just to decide which has the better flexibility for the joints. And then the digital nerve that we saw just there, which is the digital nerve to the tibial side, I always think that's a little bit more tricky to dissect out. And then the fibular side is easier because you're not worried about damaging any of the vasculature, and then taking everything out. And I wish it took as speedily as this video is, but I really clipped it down to show it, just to show the structures. And this is exactly what we do now, taking the branch of the peroneal nerve, the longest flexor tendon that you can. And then some of the things I think that are important are, it's okay to open up the plantar surface if you need to get better access for the digital vessels and for the digital nerves, I meant, and for the flexor tendon. That's perfectly acceptable. And then before, okay, I'll just move on now. That's the one that didn't work. Now all the videos are going to work. Okay, then just a few things about the preparation of the toe. So I'm sure everybody else does this as well, but I normally dissect everything off and then just leave the kind of vascular loop intact, the artery and the vein, let the tourniquet down and check it. Because what you want to decide is that the toe is definitely pink and everything is okay with it before you're going to transfer it. Otherwise, you know, if you end up a white toe on the hand, you're not really sure if it's related to something on the hand or if it's related to something onto the circuit of the toe. And if there is a problem, you know, you just have to like find it, excise the segment and repair it. And I think we've all done that on occasion. It's a bit of a panic situation, heart-stopping moment, but you just get on with it and then transfer it. And then as I said, keep everything long. That's what I'm trying to demonstrate in this picture. This is kind of an interesting case as well, because this is my first post-COVID toe, so, or peri-COVID toe, whatever era we're in now. So it's just kind of getting back up and running with all these kind of routine cases. And that's the thing. And then preparation and moving to the hand is just related to, again, the fixation point and making sure that you've got the lengths correct. And then the other things I think that are important are, you know, this is the sequence for fixation and transfer, which I don't think is any different to anybody else. You know, bone fixation first, then flexors and extensors, then take the scope in, veins, artery, nerves, skin, and then very low threshold for putting a skin graft on, in particular on the plantar surface, on the volar surface, because you know, what you don't want is anything to be constricting of your arterial system. And that normally heals really well. So it might look a little bit messy when you've done it, if there's some skin grafting, but long term, it totally goes away, and it's well worth it, because you worry far less about constricting your vessels. And that's essentially it. I think that's the end. Oh no, yeah, that's all. Just to say, I thought it might be nice to have a bit of a discussion about it rather than me being very didactic about, oh, I do this and that. So if there's anything that anybody wanted to ask or share that they do as well, we also good to talk about that. Thanks.
Thank you very much. Really nice talk. I think that there are no questions in the chat. I have some of them.
Okay.
I wrote them down. Okay. So the first, any trick to make the toe not to look a toe? Well,
yeah. So I mean, you mean pulpoplasties and things like that? Yeah. Mm-hmm. So I think, you know, generally we know the pulp is different to the digits. So I normally do that as a secondary procedure to do something with the pulp, take out little ellipses or things like that. In general, to be very honest, not very many of the patients that we have would request that. They tend, I'm talking about the congenital kids now. So because the hand is quite different already, it's quite a small hand, and the digits are different anyway, so they don't tend to ask about it. The odd teenage child will ask, and then it would be just about trying to modify it so that the pulp is, you know, a more not so bulbous as a toe. But it doesn't tend to be a big problem, but I think there are things to do to adjust it.
Okay, there is a question from David McCombe that I also want to pose. That question is, do you need any time to include the metatarsophalangeal joint, and what do you do to avoid hyperextension, etc.?
Yeah, so I think that's something, you know, obviously you try to avoid using that for that very reason, because the plane of the toe does have a better arc of extension than flexion, quite different to the digits. Again, in a lot of the congenital cases, you don't necessarily have to use the MTP joint because you really don't need it. So I guess some of those cases are cases of traumatic loss when you want to have a longer length. I don't really have a solution for that, to be honest, just like you, I think. You know, I haven't got the huge experience in taking the MTP joint with the toe. I'm just trying to think what I've done about it. No, I haven't got any kind of answer for that. Just try to avoid having to take it, or kind of double think, do you need to have that as an extra joint as well? Because you've already got two distal joints apart from that anyway. So it's very difficult to have 3 joints with the number of tendons that you're taking to stabilize everything. I think that's quite a challenge.
Okay.
So sorry.
Simo Wilke used to say that you need an extensor, a flexor, but it would be nice to have also like intrinsic function. So right and left, or tibial and so radial and ulnar tendon, also to improve function of the toe, of the new finger. What do you think about?
Well, I think that's a nice idea, but in the congenital hand where it's in brachydactyly, a lot of those the small muscles aren't there. So it is a nice idea. And in a child where, say, there's a traumatic loss, then you could do it. But in those cases, I'm thinking of symbrachydactyly where there's maybe a thumb and no other digit, or there's no thumb. Then, you know, the small muscles aren't there. There isn't any lumbrical to attach onto the side. You know, there really is just a fused mass of flexor and extensor on each side. The extensors tend to be often better. So there isn't really, and also when you're putting it onto quite a short metacarpal. So there isn't really the length for a lumbrical either, let alone the tendon excursion, I would say, but I don't know if anybody else has other experience with that.
Okay. What is your opinion about indications in symbrachydactyly? I mean, if you have only a thumb, no digits, or 2 digits in a child with 2 digits, symbrachydactyly with 2 digits, is there any indication for a toe transfer?
Yeah, I think we have a very good. Well, we have you know, if families are coming and they're exploring the option for digit reconstruction in symbrachydactyly, no matter what the pattern, we go through a whole process where they go through information gathering and learning with a psychologist and the senior physiotherapist, and they get to see the donor site, other children with a similar condition, and then, you know, it's basically a discussion with that family about the benefits of adding any extra digits. So the key thing would be that if we're going to do something like a toe transfer or any microvascular procedure, but particular for digit reconstruction, that we're going to add a new type of grip. So for instance, if the child only has a thumb and then you add 2 toes, then you're hopefully going to have maybe a pincer grip, but they probably won't come, they may not come pulp to pulp, and they may also have a slightly bigger grasp. If they already have a thumb and a little finger, for instance, which is, I think, the pattern you're talking about, and you add further, then you'll add maybe something more like a cup grasp. They can do more like that, or a span. So those are all things that we use as adults, and they're all important. So I think, you know, there's no right or wrong answer for that. Personally, I'm very, you know, I feel that the adding digits does add, because we all have them. So it does make a difference. But of course, the thing is, you also must have the muscle and tendon excursion to actually move them. And you also need to have nerves to provide sensibility. I don't know, does that answer your question? Sorry.
Thank you.
Thank you.
Jessica, can I just ask a question for a sec? That last point, Graine, I was madly trying to type into the chat box, but
sorry.
How poor does do the donor nerves and donor flexor tendons need to be before you would abandon or not go ahead with the toe transfer?
Oh yeah, no, great question. So I mean, I think that's really a difficult one, but I mean, I think, you know, if like all these hands, I mean, I think the ones Simon has always said, and it's true, when they tail off on the ulnar aspect, those children that kind of tail off, you know, when they kind of slant off to the ulnar side, those are the ones that tend to have less nerve available for reconstruction. So I think if you really go and you find there's really nothing, which is fairly rare, you know, to find no nerve, it's not that common. But at the same time, you know, you do have to kind of really think twice about it. Sometimes the nerves are very they're not really hypoplastic, but they're, you know, they're very small. So, but you know, children are amazing. They use everything that they get.
Yeah, I was going to just say, with respect to Cisco's question about the symbrachydactyly, this sort of child, I think kids, or our interface with digital equipment going forward, you know, touch pads and keyboards and this sort of thing, makes some sort of digit reconstruction pretty valuable, is my personal feeling, but it's controversial, obviously. And it also increases the diameter of the hand as a balancing structure for holding and carrying and pushing and stabilizing things even as an assist hand. So I'm an advocate for it, but,
I know,
but it's. And Daryl had a question about talking to parents about it, and I know in Leeds there's a fantastic setup with respect to psychologists and input from everybody, but I think you just got to be. It's a multiple consultation type decision. Certainly for me, it is. It's always one at the end of the consulting session, so you can keep talking to them for a while.
And I think the thing is, I see Daryl's question there. So we definitely don't persuade patients at all. I think there's a couple of things I think that I've learned a lot about it. One is, like, from Simon and Maggie is the psychologist and Fiona is the physio. They're totally fantastic. But a lot I've learned from them is, like, you know, if the parents don't agree, don't do it. If there's any doubt, don't try to persuade them, because they'll either, you don't want them to be unhappy long term. And, you know, it's just about information gathering. The fact that they maybe know that you have the skill to do that and they come to visit you, means that maybe they're thinking about it. So that's positive. But what I would say is, maybe nowadays, even compared to like 20 years ago, that I think, you know, there's a lot of acceptance of differences now. So maybe people aren't kind of running after trying to have, you know, hand again. But I think that toe transfer adds a lot to the hand. So, but the setup that we have, and Daryl, you know, totally welcome to come and visit when we have our new hospital, would be just to see the psychology and the physio. You know, just the difference that makes is really good, because, you know, we just talk to them, give them information, they go away and think about it, see what can be achieved, I think. And that's really helpful.
Great. Florian Schashinker is asking, what about the post-op, microsurgical prophylaxis, etc.?
Okay, so no, we don't do that. We have a very standard, you know, we work with the same team. So I work with the same anaesthetist like every week, and we have a kind of a set process. So the child is warm in theatre, well perfused, pain-free. So we use a lot of blocks, you know, brachial plexus blocks, caudal maybe for the toe, for the donor site. We don't routinely use any antiplatelet or any heparin therapy. They're just monitored on the, you know, in a special care area afterwards for 24 or 48 hours, depending on the child. And just in a kind of a warmish room, not really baking hot, but a little bit warmer, and sometimes kind of quieter environment, but not routinely. You know, if there's a problem, sometimes we use prostacyclin if we're a bit worried about vasospasm.
Okay, thank you very much. Thank you.
Okay, thank you. Thank you.
So I think.
Okay, yeah, I think we're done. Are we, Cisco? We've that's 10:30 or 10:30 here, 2:30 there. So look, I would really like to thank Daryl and Graine and Peter for participating today. As Zesco said, the talks are going to be available on the YouTube channel, the PULM YouTube channel. And we'll have another session in a month's time, correct?
Correct.
4 weeks' time.
It will be Dan Zlotolow who will direct that session.
I have nothing to say.
No disclosure, Stan.
No,
thanks very much to the moderators, to Scott and Dan and Zesco, and again, thank you very much for all the speakers for donating their time and expertise. It's fantastic.
Thank you very much.
bye everyone.
Thank you.
Thank you.
Bye.
Bye.
Cheers. Thanks a lot.